This podcast is supported by IHI, also known as the Institute for Healthcare Improvement, who have been improving health and healthcare worldwide for 30 years. Those of you familiar with IHI will already be aware of their work to make care continually safer by reducing harm and preventable mortality. Patients and patient safety are at the heart of what IHI does, and that's why IHI encourages the use of the SBAR technique. SBAR stands for Situation, Background, Assessment, Recommendation, and they've developed a tool to help foster a culture of patient safety in any health and healthcare setting. Learn more and download the SBAR tool at ihi.org and start using it today. While you're there, check out the many other tools and free resources available from IHI, including QI tools, health equity reports, and patient safety tools, to name a few. That's ihi.org. Check it out today. Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. David, primary care. We talk a lot about different aspects of healthcare. Everybody talks about how primary care is important, but we don't really talk about what it is.
Well, John, we can remedy that right on this episode. In fact, let's use this episode of CareTalk to dig into how the pandemic changed primary care.
Well, maybe we should start with, what about telehealth? Telehealth was this big change in primary care during the pandemic. Do you think telehealth's here to stay?
I think, John, the question, for sure it's here to stay. The question is, why is telehealth here to stay? And I think we could talk about that during our discussion of primary care. I think you want to...
Now you're just kind of criticizing the application of technology, the advancement of big new ideas. Tell me exactly what your beef is with telehealth.
Here's my beef, John. We said, let's talk about primary care. We never have a chance to talk about it. And then you say, no, let's actually forget about that. Let's actually skip over just to the sexy topic of telehealth. I think we should start with the basics, the fundamentals. The primary portion of this podcast should be on primary care, John.
Okay, so fine. So we will slow walk the basics so that you can catch up to what the rest of the industry is talking about, which is that primary care, in the middle of value-based care, in this massive movement to value-based care, couldn't be more important. So fine, David, let's explain how do you define primary care?
Well, John, it's a good one, and it's like the sort of thing when you say there's no stupid questions, except if I can't come up with a good answer, then I don't know what to say about that question. So, what is primary care? Well, one thing I heard it described as is, a primary care doctor is a doctor who specializes in not specializing. So like your classic general practitioner that has takes care of everything that comes at him. The American Academy of Family Physicians, who are basically primary care doctors.
Oh.
Yeah. They talk about integrated, accessible healthcare services. And they talk about...
there's a footnote.
Yeah.
I don't even know what that means.
Which part? Healthcare? So, no.
What does integrated, accessible care mean?
Yeah. No, it's a good one. So, basically it's a team approach. I don't know, John. Integrated, it's better than actually. Later it comes to a weird part of the definition where it talks about practicing in the context of family and community. So the basic idea is these are doctors that can take care of most of what you need. And actually it's not just doctors, but the AAFP is just doctors. So what they do, they take care of preventive care, can handle the occasional acute illness, and they play a really important role in chronic condition management, John. Those are sort of the functions.
You're kind of struggling with all those big words. Isn't really what it comes down to that your primary care doctor kind of knows you and knows everything and does nothing, and your specialists, the surgeons and the specialists, really do everything but don't necessarily know who you are. I mean, the most important thing about primary care, I think, is that it's your gateway to healthcare. It should be a doctor in a doctor's office that knows you and knows your problems, that sometimes is there for kind of urgent advice, but is there for the everyday, whether it's regular healthy care or chronic sick care, but really knows who you are and can help coordinate and manage your care. The ideal is the Marcus Welby, the local neighbor who knows you and your kids and your family, and who can actually help. And then from a managed care perspective, It's really they're doing the care traffic control.
John, you're bringing a tear to my eye, the Marcus Welby reference. But another way to think about primary care is you could call it the 7% solution, John, because that's actually the percent of total
Oh,
healthcare spending that is expended on primary care. So I don't know what specialists do, but I know that they take home 20% of the pie, and hospital 38%. So primary care is maybe because it's primarily doesn't get paid.
well, it's a real problem. I mean, the average internist, pediatrician, the general practice of primary care is often paid, 20 to 30 cents on the dollar of what a specialist would be paid, what a cardiac surgeon or an eye surgeon or any of the interventional specialties. And one of the other challenges in this country is that, I think probably chasing compensation, 70% of all the doctors are specialists and 30% of them are primary care doctors. Whereas in the rest of the world, 70% of the doctors are primary care orientation and 30% are specialists. And that may have something to do with the fact that everything in the United States costs so much because the care is going to the most expensive part of the healthcare system. But the reason why I think primary care is so essential and why it's worth digging into is we absolutely need primary care if we're ever going to get our arms around chronic care management and connecting you, David, with all of your chronic care and social and emotional issues
Yeah.
with someone who can help coordinate your care.
That sounds good, John. Now, listen, we talked a lot about tertiary care, and we're doing a long podcast here on primary care. I think a podcast on secondary care would be pretty short because I don't even think that exists. They just skipped right over it, John.
So tertiary care, but tertiary care is care in a hospital. Let's explain it for people.
Okay,
Let's not get into your integrated whatever. And then primary care is really that care that really is now when you think about it, David, all of the burden, or much of the burden rather, of the pandemic really hit those primary care doctors and nurses very hard, who were they were kind of the heat shield for the pandemic, getting hit with all of the questions and the care for everything from the average sniffles to folks who had to be intubated. I mean, it's been a very difficult couple of years for, again, the most important hinge point, access point of the healthcare system, which are the doctors and nurses that are the first line of who you need to actually get care for you and your loved ones.
Well, John, it's fair enough. And let's point out that, there's about 300,000 primary care providers in the U.S. About 200,000 of them are physicians. The rest, about 56,000 nurse practitioners and about 30,000 physician assistants. So it's not just doctors, although it is primarily doctors. You know what?
Well, it's a great point because it really a lot, because primary care, which is the care that you need when you're with your first step in healthcare, it's a team-based sport.
Let's talk about what happened during the pandemic with primary care. The first thing that happened, John, is that a lot of the practices just shut down, and of course they talk about they didn't get 7%, they got 0% of the income right there at first. Plus, when they started to open up again, they had to have new expenses like personal protective equipment. And the other thing that happened is a lot of them are small businesses. So like a lot of small businesses out there, they were nimble. They figured it out. They had a lot of challenges, but they figured out, they more or less figured it out, and they did shift right away to telehealth before they even knew if they'd get paid for it.
Well, I think one of the things that remember the reason why they shut down quickly is because they're largely fee for service. Not everybody's moved to value-based or capitated or being paid on a budget. Secondly, those offices were super spreaders potentially for people getting sick, and it was really tough on the staff and the individual participants. So their income went to zero, and they became dangerous places to work. But the CARES Act and a number of other supports from the federal government kind of funded the transition to the other side of the pandemic. But I think, David, what's sort of interesting is it accelerated the transition of we've historically in the United States had really the primary care, your local neighborhood doctor has been to your point, a small office, a small business, but there is an underlying aggregation of doctors where, gosh, by 2018, I think close to 60% of all doctors were we're basically in some form of an employment contract with a large doctor group or a hospital. And I've got to think that's accelerated. And we're going to lose. And what I worry about is we're going to lose some of that neighborhood feel that you had with the independent doctors. But if the pandemic proved anything, it's that as an independent doctor's office in a crisis, you're put under extreme financial duress. I think one of the impacts of the pandemic on primary care is it's going to force more folks to sell their practices or just go and become employed docs.
Well, John, the numbers are not all in, but I do understand that there was a sharp increase in the number of acquisitions of these independent practices by the big systems. Now, if you think about it, you mentioned that primary care did a lot during the pandemic. I know my own primary care physician, helped keep me from having to go into the emergency room or to the hospital when I had COVID. They help care for the patients once they're out. But there's a couple of things that have happened that actually may accelerate their demise. So one was the financial stress or duress or dress or whatever it is that you talked about before. That's part of it. But if you look at what they didn't do, they did not make the primary care physician office the focus sites for vaccination. So, even though with the hesitancy about the vaccine, your primary care physician in the context of that, I guess, integrated, holistic relationship, actually can persuade people to get vaccine as part of their overall care. So they were not really the focus for vaccination or for testing, and they've had the financial strains. So we're probably going to exit the pandemic with less primary care and less of fewer of the Marcus Welbys and, not very many independent practices.
Well, it's an interesting challenge because a lot of the move to value-based care where you could get kind of healthcare on a budget and you could be paid on outcomes as opposed to activity really depends on more primary care. And as many as 500,000 docs and nurses who were providing care during the pandemic are actually thinking about retiring. I mean, I think that by 2021, by 2025 to 2030, we're going to be close to a 50,000 plus doc deficit based on projections that were pre-pandemic. I can't imagine what's going to happen if the number of doctors starts to retire even faster. And these jobs were really hard. I mean, the reason why talking about primary care in the pandemic is so important is that typically doctors and nurses were working 50% more and putting themselves and their families at risk in the middle of this pandemic. So at a time when we've got 10,000 people turning Medicare eligible every day, the boomers are now graduating into the period of great chronic care needs. We've got doctors going the other way, and we've got screwed up immigration policy. There's 10,000 nurses, David, at a time when 1 out of every 3, 1 out of every 5 nurses wants to quit. We've got 10,000 nurses who are qualified, who are stuck in the bureaucratic mass of our screwed up immigration bureaucracy. And I think you're going to have to see the way we actually solve the supply and demand problem that's emerging around demand for care and supply of talent is we're going to have to open up those gates for immigration for qualified docs and nurses.
Yeah.
Because we'll never get to better value-based care if you can't find a doctor to access it from.
Well, John, I get a little confused with your statistics. There's 10,000 nurses turning 65 every day. It's definitely a challenge to to be able to deal with. Now, I want to get back to one of your questions that you asked early on. I know you wanted to get to. I mean, why is telehealth here to stay, John? Why is it?
Oh, it's obvious. I mean, come on. Look at what you're doing right now. We're using a televideo technology to communicate and connect with our beloved audience.
Right.
Why wouldn't we? I mean, healthcare is the only place. Healthcare subsidizes the fax business. I mean, we have to lean into new technologies, and telehealth simply provides another kind of omni-channel opportunity for doctors and nurses to be able to communicate with their patients. I mean, why wouldn't we do it?
Well,
what's your solution for the homebound elderly person? What's your solution for making a doctor's day more efficient? What's your solution for reconnecting? I mean, you're not answering any of my questions.
John, this is like telebullying. There's no reimbursement for that. I'll tell you that much. So, what happened, the reason telehealth hadn't been used before, one, it wasn't reimbursed. Before the pandemic, it was only 1% of primary care visits were telehealth. It shot up to about 80%, now back down closer to 20%. I think it really depends on reimbursement policy. There are some issues, John, with telehealth, although I think this would go both ways. one that people talk about is about, issues of equity and making sure people have access. Now, on the one hand, maybe people that have more means are more likely to be able to get online and so on. But on the other hand, those are also people that could take off half a day to go to the doctor's office. Whereas if you've got telehealth, you're in the break room, you're on your lunch break or before or after sitting in your car, you can do a telehealth visit with a phone, which most people have. So I think it's just a matter of being conscious to make sure that we use telehealth not to exacerbate disparities, but actually to reduce them. I think it's eminently doable.
No, it's a really good point. But I mean, there is that Medicare statistic that theoretically it's going to cost Medicare another 20 to 30 billion dollars if they permit telehealth visits. For me, it isn't a question of how much the televisits are going to cost. It's whether they can actually drive, to your point, more connection and collaboration between caregivers, patients, and the care providers. And I think the question is framed the wrong way. I mean, but we have been historically incredibly conservative in healthcare at allowing technology to actually accelerate, and this is purely a connecting issue, and I think you are going to see more and more health insurers, and hopefully the feds in the states, to find appropriate ways to compensate and support those connections, because it actually it is a bridge to sort of solving some health equity issues for folks who are working two jobs and either sick or have sick children or parents themselves.
John, I got another question for you. So, we talked a lot about the primary care practices being sucked up by the big hospital systems and so on. But also, as I was talking about the vaccines and testing, a lot of that's been done in some of your big drugstore chains. I'm thinking like a Walgreens, a CVS, a Walmart, and some of those players are getting into primary care as well. And I think they're figuring, hey, I'm kind of offering primary care. This is what primary care is these days. Why not go broader? I mean, how do you feel about that movement?
Well, I think it's really exciting, because I think that there aren't any healthcare providers that have anything close to like a phenomenal Apple product, Apple store, Apple service kind of like experience. And so the talent and the leadership that has started to build that into our pharmacy chains and has a better sense of how to connect and communicate. I think bringing that talent and merging it with some of the provider talent, like with Walgreens and VillageMD, is only going to provide more innovation and kind of more access, I think, to patients. The other challenge you've got with, again, the healthcare system has been a you show up and sometimes we serve and care for you kind of model.
Yeah.
I think we can make the access to chronic care advice, chronic care support more accessible. And we've got, I don't know, close to 40 to 50,000 retail pharmacy locations in America. If we can actually leverage those locations to give people more access to care, drugs are increasingly more important for continuity of care. Putting that all together in a local neighborhood where, again, not going back to Marcus Welby, but a neighborhood location where you actually know the person who's caring for you, I think could be really exciting.
John, it's interesting because these chains have also experimented with other kinds of approaches, like, urgent care clinics that are not actually meant to be primary care. They don't handle like the chronic conditions and so on. They're making some tremendous investments now in the primary care side. So you mentioned Walgreens with the VillageMD investment, about $5 billion investment from them. Clearly, Amazon is doing a lot with their service. CVS has something like 1,500 health hubs that they're moving in that same direction. And Walmart, their ambitions go, interestingly, beyond primary care. Some of their clinics are more comprehensive and, John, do I dare say integrated, that are covering a lot of different specialties. But all these big players adds up to less room for the small guys, or frankly even for the health systems. I'm not sure that's a bad thing from a consumer standpoint.
Yeah, I think what I like about it is the level of innovation. Walmart is also really investing in virtual care. I think that Aetna, CVS, and Walgreens Boots Alliance are thinking about how do you integrate pharmacists in, and pharmacists have historically not been integrated. They're thinking about how do you put together a care team that might have some more mental health professionals, make that more accessible. Walmart has invested in kind of computer-assisted diagnoses. I think what's interesting about these new players is they're going to be more rapidly investing in newer models, and that's got to be all to the good for the American patient and consumer. They're not all going to win.
Yeah.
They're not all going to work, but it's not like there's not tremendous opportunities to improve the consumer experience in healthcare. And that's not just about a consumer choice. It's about how you access and get the care you need when you need it in a way that you can utilize it. And that's where I think there's tremendous opportunity for these big retail players and their perspective on what kind of bets they can make, whether it's virtual care, whether it's playing around with integrated care with pharmacists, leveraging some of the AI technologies, the learning technologies, and also, frankly, providing access to care for folks in underserved communities. I think it's exciting that they're jumping in.
John, I want to ask a last question here. Maybe we can both weigh in on this one, which is, would you advise someone, to become a primary care physician? Let's say somebody graduating from college thinking of going to medical school, or someone coming out of the medical school and thinking about what they want to do for a specialty. Primary care, how would you rate it?
It is and will increasingly be the most important part of the healthcare system. I think it can be an incredibly rewarding career because you really are providing the care that people need, practices when they need it, and you've got a relationship in the right practice with your patients. I can't think of something that's a more admirable profession, and I think the demand is going to continue to grow.
I think it's a good place to go too, John. I mean, it's been a sort of thankless job in that doesn't pay all that well compared to the specialties. You still got to do all the training. You got the medical school debt, and so on. And in some cases, a primary care is just seen as like a gatekeeper for trying to get to the specialist. But I think this is coming, if not a golden era of primary care, at least a silver era that's going to be pretty good. And you actually do see, I know, John, you mentioned earlier in the show that a lot of physicians were thinking of retiring, leaving the profession. When you look at it from a primary care basis, the primary care doctors are not so much like that. They definitely were talking about burnout and stress, but they're actually kind of sticking with it. And I think that what we've seen is that primary care really has done a lot in dealing with the pandemic. And so it's becoming seen as a rewarding career choice. And we actually are seeing people be interested in it. So I think they're making the right move. And I think from a societal standpoint, it's a wonderful thing, John.
Well, and frankly, from a value-based care perspective, now they're going to be paid bonuses and incentives to actually deliver the care that some of the best doctors are already delivering. I think this could be a real golden era for primary care, not just for docs, but for nurse practitioners, advanced practice physicians, for PAs, for that anyone who's involved, for those retail, those centers that have primary care. I think this could be a golden era and growth clearly for those areas, for those providers. I'm really excited about it.
So, John, we've covered a lot in this episode on primary care. After my initial struggles to define, what the heck it is, we talked about telehealth. We talked about who's providing care. We talked about how much is getting paid and who isn't. We'll have to talk another time about direct primary care and concierge. That'll be for another show. Talked about Walgreens.
We talked about high-end, your high-end specialty concierge, Boston doctors.
Now we're talking, John. Actually, I think we'll have to charge a fee for anybody who wants to hear that show. So before we get into giving away any of that primary, tertiary, or quaternary content, I'm just going to say that's it for yet another episode of CareTalk. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. If you liked what you heard or you didn't, please subscribe on your favorite service.